Welcome to our third webinar focused on the deployment of public health and medical resources through EMAC. I'm Angela Koppel, the EMAC Program Director at NEMA and your host for the webinar. We have an excellent panel of speakers today. We're going to start with Cris McCombs from Hagerty Consulting, followed by Carol Walton with the Arkansas Department of Emergency Management, then Greg Shanks with the Kentucky Division of Emergency Management, Kate Archie and Cindy Shelton from Virginia. Kate's with the Virginia Department of Emergency Management and Cindy is with the Virginia Department of Health. And I'm going to go ahead and kick it over to Cris to kick us off. Thanks, Cris.
Good afternoon, everyone. Thank you, Angela. As Angela said, my name is Cris McCombs, and I am with Hagerty Consulting, and welcome to our discussion this afternoon on mission-ready packaging for the medical and public health professionals. We want to thank you for the gift of your time today, and we have a great 90 minutes planned, and we're anxious to get started. So let me provide a little historical backdrop on how the project was conceived. The National Emergency Management Association, in partnership with the Association of State and Territorial Health Officials, known as ASTHO, recognized that there existed a deficit of public health mission-ready packaging. That when you went into the mutual aid support system, better known as MASS, that is the technology infrastructure housing all of the packaging, in fact, there were not many packaged for the public health community and available for deployment through EMAC. Acknowledging this deficit amplified the need to take action on the problem. It is important to note that this challenge was not unique to the medical and public health community, but perhaps the way we went about addressing it is in fact unique, and we hope it provides a roadmap that other disciplines may choose to replicate. Now that we have identified the challenge, we sought to convene an advisory group made up of thought leaders from across the country. The advisory group began meeting in January of 2014 to begin the process. Membership included representatives with expertise in public health, medical, and emergency management. And the map before you represents our contributing membership over this 2-year time frame. We had a fabulously diverse group that included federal, state, local, and association members with geographical variation and variation in life experiences, which contributed to our success in working together. The first order of business was to set forth our objectives. In Phase 1 and in Phase 2, we sought to determine where the most commonly requested public health and medical resources were that were needed during times of disaster and other public health emergencies, and wanted to commit to developing templates to support the building of mission-ready packaging for those resources. Okay, now that we knew that we wanted to create templates for the most commonly requested resources, we now needed to identify 5 pilot states and to go into those states to work one-on-one with their EMAC coordinators, public health officials, and key members of the emergency management and medical community to create state-specific, customized mission-ready packaging and committing to uploading those completed packages into the mutual aid support system known as MASS, which again is that technology solution, the infrastructure that houses the MRPs, giving visibility of all available resources to everyone across the country. During Phase 3, we conducted day-long sessions dedicating the morning session to educating folks on EMAC. In some cases, there were members of our audience that heretofore had not heard of EMAC, while others had some vague understanding, and these sessions helped broaden and deepen their understanding of EMAC and how to use it. The morning session generally had a broader audience than just the public health and medical officials by design. We included a number of disciplines with the invitation list with the goal of improving folks' understanding of EMAC, and if we did our job correctly, getting the other disciplines in the room excited to also start building mission-ready packaging for their respective disciplines as well. To support our objective, we now needed to determine what were the most commonly requested public health and medical resources and also wanted to understand what resources had previously been typed by NIMS. We first looked at all of the EMAC activations from the year 2005 to present day, and we captured all of that information regarding the public health and medical MRPs that had been requested. As you all know, the MRP also based on NIMS resource typing. So to complement our research, we reviewed what public health and medical assets had previously been typed. The work group also reviewed applicable guidance documents, such as the JCO standards for healthcare facilities, to help inform required resources that might be needed by the healthcare facilities during a disaster or a public health emergency. We also reviewed HPP standards, FNSS guidance, and lastly, the CDC state and local public health capabilities document. The work group then analyzed all of available data and voted using a sliding scale on what they thought was the need for the most requested resources to the least requested during times of disaster or public health emergency. Taking the results of this ranking, we now had a clear vision of what our 16 templates that we needed to create. This slide that you're looking at, for those that are dialed into the webinar, is a representation of those 16 templates. You will see on this slide that in phase 1, we had developed 10 MRPs that spanned across 4 public health and medical priority areas: fatality management, mobile field medical care, shelter and functional needs support services, and medical surge. In phase 2, we developed an additional 6 based on the following public health and medical priority areas, to include epidemiology and surveillance, RAD monitoring and decontamination, foodborne illness detection and surveillance, public health and medical operations support, and lastly, medical support for shelter operations. You will see here on this slide a full representation of all 16 public health templates, and we were now ready for phase 3 to begin working with our 5 states, the states of Arkansas, Kentucky, Louisiana, Virginia, and Wisconsin. What an amazing and enthusiastic group of industry leaders. They were extraordinary, and we were so honored to work with each of their states. Their commitment to building and maintaining a strong EMAC system was truly laudable. With our team now in place and the excitement around this process building, we began to customize the templates and committing to uploading them to MASS for all EMAC users to gain visibility and possible access to such resources in times of need. As we prepare to transition to our next presenter, I wanted to give you a snapshot of the templates selected by the 5 pilot states. A couple things to note here. I've listed on the next 3 slides the category of mission-ready packages that the state's public health and medical teams committed to building. It's important to note that within each category, the state team may have built multiple packages of the same resource, providing even greater depth into that particular resource should there be numerous requests for the same resource. What I'm going to do is highlight all 5 states, and as Angela said at the beginning of our webinar, we're lucky enough to have representation from 3 of our 5 states on the call, and will, in a moment, all 3, Arkansas, Kentucky, and Virginia, will provide a deeper dive into what their team accomplished. For Arkansas, they chose 5 categories to customize, and they selected ALS Patient Transport Team, BLS Patient Transport Team, Bariatric Ambulance Team, Behavioral Health Team, and Foodborne Disease Epidemiology Team. Kentucky developed 5 categories of MRPs: Epidemiological Surveillance Team, Behavioral Health Team, Medical and Public Health, Technical Support, Patient Transport Team, and Radiological Monitoring Team. Louisiana chose 4 categories to customize, and they selected ALS Patient Transport Team, BLS Transport Team, Bariatric Ambulance Team, and Pre-Hospital Acute Care Team. Virginia chose 7 categories to customize, and they selected an autopsy team, a behavioral health team, epidemiological surveillance team, a Fatality Management Family Assistance Center, Fatality Management Scene Recovery Team, Patient Transport Team, and Radiological Monitoring Team. And lastly, Wisconsin chose 6 categories, and they selected ALS Patient Transport Team, BLS Patient Transport Team, Environmental and Public Health Technical Support, Epidemiological Surveillance and Investigation Team, and Functional Access Service Team, FAST, and also Radiological Monitoring Team. Now what I'd like to do is I have the distinct honor of passing the phone to Carol Walton from the state of Arkansas and ask that Carol be provided an opportunity to highlight all of their extraordinary efforts put forth by the Arkansas state team. Welcome, Carol.
Thank you, Cris. Good afternoon, everyone. Before I dive right into the Arkansas portion of the webinar, I want to take just a moment to thank everyone who had a hand in creating the MRP templates, in developing the project concepts, and conducting the workshops. To be honest, this was the easiest group of MRPs we've developed in Arkansas because the group of people that worked on all of this did a lot of the work for us. So I highly recommend that other states take advantage of any future offers for projects of this kind. As Cris mentioned earlier, these are the 5 MRPs that Arkansas chose to work on. When we received the MRP templates developed by ASTHO and began to discuss which MRPs we wanted to develop, we not only looked at the resources available in the state, but we also looked at previous requests and deployments through EMAC to help us make the decisions of exactly which MRPs we wanted to begin with. From a public health perspective, we decided that the need for patient transport seemed to come up pretty often, so we started the project with transport teams and moved on from there. As we go through the next 3 slides, I'll go into a little more detail on each of the MRPs that we developed. Our foodborne disease EPI team consists of a team lead, an EPI interviewer, 2 data entry members, 1 clinical development nurse, 1 field epidemiologist with a background in foodborne disease, and 2 registered environmental specialists. Ideally, this group would augment local capabilities to help characterize an outbreak, identify the source, and recommend protective actions for that outbreak. The behavioral health team is made up of 1 graduate-level practitioner, psychologist, or other clinician leader, and 2 graduate-level practitioners or psychologist specialists. This team delivers mental health services to incident survivors, first responders, and any others that may be identified by the requesting jurisdiction. They work with both adult and children populations. Our bariatric ambulance team consists of 6 EMTs and 6 paramedics. Ideally, the team would augment an existing emergency medical service and provide patient and medical facility evacuation support, patient triage, treatment and transport, and on-scene medical care. This team also comes with 3 bariatric ambulances and sufficient quantities of bariatric supplies and equipment to support the first 72 hours of deployment. The ALS Patient Transport Strike Team includes a total of 11 personnel, which will be divided among 5 ALS ambulances. Each ambulance will be supported by an EMT or advanced EMT and a paramedic, or by 2 paramedics. The 11th person in this group will be in charge of a support vehicle that will take care of the routine resupply of the 5 ambulances for the first 72-hour time frame. And finally, our BLS Transport Strike Team, which also includes a total of 11 personnel, which would be divided among 5 BLS ambulances. Each ambulance would be supported by an EMT or advanced EMT and a paramedic, or 2 paramedics. And for this team also, the 11th person would be in charge of a support vehicle that would take care of those routine resupply needs in that first 72 hours. This resource is obviously very similar to the ALS patient transport MRP. Really the only exception to this is that they are BLS ambulances rather than ALS ambulances. I don't want to spend a lot of time on the progression of the project, but I did want to take a brief moment just to show how much Hagerty contributed to the success of this project. They not only provided the project overview, goals, and templates, but also conducted the workshop for the state staff who would typically assist us in conducting workshops. I really think this was a nice change of pace for our resource providers because they got to listen to a new workshop team's perspective and past experiences rather than hear repeats of Arkansas experiences that we have given during previous workshops. But the groups that I most want to thank are the ones listed on this slide. These are the groups who decided that this project was important enough to make it a priority in their busy schedule. They reviewed the templates, our state resources, and historical data to help determine which MRPs they wanted to develop. Then they attended the workshop and spent their valuable time gathering the data needed to complete the MRPs. So a big shout out to each of them who had a hand in the completion of the packages. And finally, I just want to briefly mention 3 outcomes from this project that will continue to help us move forward in the future. First, we chose to complete a mission-ready package for a behavioral health team. We had just our state-level resources all the way down to community-level resources to ensure that we had the capability to develop this package. By including all these other resources, it helped build a stronger networking tie for us as a state. Second, we had in the past worked to identify patient transport teams and build MRPs for these teams. We had not yet refined these categories of specialized use, though, so this project gave us that extra incentive or push that we needed to improve our existing categories. And last, we took an existing EPI response mission-ready package and included this category of foodborne outbreak response capabilities, which we had not done before. This will not only help us be more prepared on a national level, but by this more in-depth capability identification, it will help us be more aware of our resources and therefore more prepared on a state level. This concludes the Arkansas portion of the presentation, so let me take this opportunity to introduce Greg Shanks, who will be speaking for the Commonwealth of Kentucky.
Thank you, Carol, and good afternoon, everyone. So we're going to follow kind of a similar format of what Carol did in Arkansas. So our related MRPs that we developed, again, are the epidemiological surveillance team, behavioral health team, medical and public health operations center, a patient transport team, which kind of evolved into a more of a strike team for EMS, and then also a radiological monitoring team. I want to take a second to talk about the decision-making process on what MRPs we were going to develop. First, we looked at our in-state capability. What were our key resources that we already had established that inside the state of Kentucky? And then to caveat that, you really have to look at the personnel. As with most MRPs, we have agencies that are able to organize a variety of different packages. However, they may have similar personnel within those packages. So that really needs to be taken into consideration. And remember that those personnel are what makes up an MRP. Those personnel are organized, train, and they also exercise together. That's an important consideration when developing an MRP. Scarce resources. We looked at some of the resources, again, that Cris talked about on a nationwide level that we see a lot of requests for, but maybe not a whole lot of teams nationwide, such as the surveillance teams. And then also unique resources. What resources do we have that may be able to bring to the table that are unique to behavioral, unique such as the behavioral health team. We'll talk about a little bit now about each of the MRPs. First is the epidemiological surveillance team. The owner of that team is our Public Health and Preparedness branch, and it provides personnel basically to go out, conduct tracing, patient tracking, things of that nature. Some hot topics right now that we'd be looking at is what's going on with Zika, and then last year into 2-3 years ago with the Ebola. Next team is going to be the Behavioral Health MRP. We're fortunate here in the Commonwealth of Kentucky to have a full-time staff, and that's the Kentucky Community Crisis Response Board. They coordinate behavioral and mental health services for disasters, and what they can provide is first a comprehensive needs assessment for each victim. That also includes evacuees. We've done that before, especially we're a host state for any hurricanes, for those folks that may need the mental health services, and that also includes first responder counseling services. Our next MRP is for the Department of Public Health Operations Center, known as the SHOC, and that's to augment those personnel. A lot of times, especially when you have surveillance and a extended outbreak, you'll see those activations in the State Health Operations Center operate on an extended level, so staff are needed to augment the State Health Operations Center. This is our EMS strike team, and it's made up of 45 personnel. Our owner of that is what we call K-Beams, and that is the Kentucky Board of Emergency Medical Services, approximately 45 personnel. It is mainly made up of local resource providers, local county and city ambulance squads that make up that unit, and they can do a variety of things, medical unit support, advanced life support, evacuation support. Again, as I alluded to, Kentucky serves as a host state mainly for hurricane evacuation. And then lastly, we developed a radiological monitoring team. That team has 5 personnel, has quite a bit of technical monitoring equipment, as you can imagine. And again, we can place them in a variety of places, both pre and post decontamination, and we can also place them prior to evacuees or victims arriving to a community reception center. So let's talk about some of our outcomes. One of the things that we were able to do is not only reach out to our ESF8 partners, but also get the folks there to the table that needed to be there. Not just the technical experts who were there, but also the health planners and, importantly, the financial staff to be able to complete the MRP. I would really strongly suggest when folks are developing MRPs cannot be developed in a closet with one person. It takes a team to be able to develop these MRPs. Some of our outcomes, as you can imagine, we were able to not only develop these MRPs, but also our MRPs now reside into the Mass Mutual Aid Support System. So we are going to be able to effectively and quickly organize and respond to requests for states for assistance. Also, we live in a grant-funded world. The majority of states, whether it be the health departments or emergency management, are grant-funded. So in Kentucky, we were able to look at our state preparedness report and our SIRA, which identified our hazards and resource gaps, and we were able to tie those back into the core capabilities that are listed into the national preparedness goals. So that was a win for the state. And then also, lastly, like I said, we're just better prepared with the EOC support teams and incident management teams in preparation of high-profile extended events such as Zika and Ebola. Other accomplishments, we are getting ready to start a year-long planning process and a plan rewrite for our new Madrid seismic event, the earthquake that's centered around western Kentucky. And we feel like we're better prepared to be able to approach that because of the development of these intrastate MRPs and intrastate MRPs, and then also being able to identify, go out and identify within the FEMA, not only within FEMA regions, but nationwide, who has what out there. I think it's a great win for the medical MRPs, especially now the ones are en masse. We're going to be able to go out as state EMAC leads. I'm speaking to state EMAC leads. Go out and kind of look and see what's out there. I would encourage the state EMAC leads to do that prior to an event. Reach out to those folks and talk to them about their package. And you may be able to get a prescriptive mission assignment where if you do have a catastrophic event, you know you're going to be able to call those folks up and depend on them to come assist you in your event. And that's all I have from Kentucky. I will now introduce our partners from the Commonwealth of Virginia, Ms. Kate Archie and Ms. Cindy Shelton.
Thanks, Greg. Hey, everybody. Before we start talking about Virginia's success with this project, I wanted to thank ASTHO, NEMA, and Hagerty for letting us participate. This has been tremendous for Virginia. It's given us some steam for building more mission-ready packages and strengthening the relationship between the Virginia Department of Health and the Virginia Department of Emergency Management. First, to start out, we really focused on the workshop goals. The first being to provide an overview of mission-ready packages and how they support EMAC and intrastate mutual aid both. We initially planned on developing the 6 MRPs listed on this slide, but as Cindy will go into later, that grew a little bit. So Virginia Department of Emergency Management started out inviting VDH, and then VDH invited their ESF 8 partner to come and join with us. And that partner is the Virginia Department of Behavioral Health and Developmental Services. So our workshop was on February 24th, and we divided it into the 2 pieces. One was the intro, and the second was really the hands-on nitty-gritty. So for the first module, the morning part, we really talked about how the MRPs fit in with Virginia's mutual aid programs and EMAC, and talked about what a mission-ready package was, really starting at the ground level. And so for this morning session, VDEM invited all of the ESF leads and VDEM's 7 regional coordinators.
As you may realize, as I go along, the Virginia Department of Health didn't have any mission-ready packages when we started working on this process. Our experience had been in deploying individuals to other states through the EMAC process. So we were really excited to get a little bit more footing in the whole process. Our intention was to invite those who were to develop the MRPs immediately. And so we had them come to attend both the morning and afternoon sessions. However, since we knew we were going to develop more MRPs in the future, we invited other agencies and offices within the Virginia Department of Health to learn more about MRPs and the system in the morning session. Those offices and agencies included the Virginia Department of Health Office of Human Resources, Financial Management, Drinking Water, and Environmental Health Services. We extended an invite as well to the Virginia Hospital and Healthcare Association because they provide oversight to the state's healthcare coalition.
So after the introductory morning, we went into really the hands-on mission-ready package development, which was the amazing folks at Hagerty walking through the whole group, field by field, talking about how to create a mission-ready package, talking about what data needs to go into what field, and doing some troubleshooting and discussion. So then we also had some representatives from health.
And those included the Virginia Department of Behavioral Health and Developmental Services, the offices of epidemiology, the Chief Medical Examiner's Office, Emergency Medical Services, and Radiological Health.
So to follow up the workshop, each group individually completed their own individual mission-ready package with some phone consultations with Hagerty and VDEM, providing technical assistance. And then once the mission-ready packages were completed, they submitted them to VDEM for inclusion into Virginia's inventory, and also VDEM would then upload into MASS. And so all of our mission-ready packages were completed and uploaded in early April. So then we were fortunate enough to follow up the workshop and the mission-ready package building with an exercise. And so our exercise was Operation Helping Hand, and the scenario essentially was that Ohio was requesting a radiological monitoring team from Virginia. So we had this on August 3rd, and VDEM and VDH and Hagerty planned the exercise. Some of the key issues that we were hoping to address were decision-making, communication, VDH and VDEM procedures, and reimbursement. And then here's our agenda.
So this exercise provided VDH with the opportunity to validate the CMAC procedures and supporting documents. As you'll note on the slide, we chose to exercise our radiological monitoring MRP using the team lead and their office business manager as representatives from VDH. We also included a representative from the Office of Human Resources to discuss or answer questions regarding some of the supporting documentation that was developed previously. We invited all of the MRP leads and representatives from the Office of Financial Management and Human Resources to observe, but also to learn more about the procedures and packets that we had developed to support MRPs. We revised the procedures that we had to make them a little bit more clear, and we did develop some additional supporting documentation. What made this exercise most interesting for me personally, and from Kate and from others that I've talked to, was the engagement of the observers. They got very involved in this tabletop and started asking questions and providing feedback, which was actually encouraged by the exercise facilitator. And that feedback is going to be very helpful for us and will be incorporated within our after-action report improvement plan. So as far as the outcomes go, I'm not going to read all of the stuff about these, the teams that our packages that we've developed, but I can say as a result of the workshop that was held in February, we ended up with slightly more MRPs than we anticipated. We did get the autopsy team of morgue operations, which actually has the ability to have up to 4 3-person teams. We have the behavioral health team that was developed by the Virginia Department of Behavioral Health and Developmental Services. Our epidemiological surveillance team says it has a team of 10, but that can be scaled down if necessary. Another MRP we developed, and this was one that actually got developed as a result of the workshop, was the Fatality Management Family Assistance Center unit. And then we also have a Fatality Management Scene Recovery team, which consists of two teams, two-person teams. Of course, our radiological monitoring team, which participated in our tabletop. We developed 3 different patient transport teams. They were pulled from 3 of the EMS regions that are around the state, and they have the possibility of either being ALS or BLS, depending on the need. The individuals that will be supporting these teams are not health department personnel. They will be pulled from local volunteer and career providers.
So in addition to the actual MRPs, which were the main goal, we also had some great outcomes. One of which was increased mission-ready package exposure and familiarity. This was a fabulous opportunity for partner agencies and localities to learn more about mission-ready packages and how they fit into Virginia's mutual aid systems. Also, we came away with a great workshop model, which we are planning on reusing for many years to come, I'm sure, with making it discipline specific for other areas. So we've got a great tool in our back pocket now. Thank you, Hagerty.
The other thing that happened as a result of all of this is the realization that we needed to revise our EMAC procedure. And so we actually developed a cleaner, streamlined procedure for EMAC offers and reimbursement to assist our office areas should there be a request for EMAC. In addition to that, we had a couple of supporting documents to help people who were deployed, but we realized that they also needed to be revisited and revised. So in the process of all of this, we developed additional packets and supporting documentation. So let me share with you what these job aids are. One is a packet that will give the office business managers, who are the ones charged with the actual reimbursement process and keeping up with who gets deployed. And this package includes information about what EMAC is about and what the business manager needs to know and do towards supporting a mission, such as making transportation and lodging arrangements. The reimbursement procedures for the health department are in there, as well as for the state, emergency management, and what to discuss with those folks that are being deployed, as well as the forms that they need to have. A second job aid, and this is one of the 2 that we already had but revised, goes to the team lead, who will be sort of the mother hen of the participants that actually get deployed. They'll all be together. And that team lead also has checklists that will assist that person with what they need to do regarding personnel, regarding keeping Virginia in the know, like calling in every day or submitting information to the Department of Emergency Management as well as health. How to mobilize and demobilize folks when the mission is over. And that third packet I'm going to mention is the second of the 2 job aids, and that will be given to the participants. That includes, again, a little more information about EMAC so people understand what they're doing, as well as what they need to take when they go or respond to the mission, a section on FAQs, forms like their labor record, like their timesheet, and that kind of thing. So it was a really wonderful opportunity, and now we have something that we're going to distribute to the offices that have MRPs so that they'll know what to do. As you all know, most of us have turnover, and when new people come in, typically they come in pretty cold and don't know really what to do. So hopefully these procedures and supporting documentation will assist in our endeavor with EMAC. The validation of our procedures really came through with this exercise that we had, especially from the observers. and it allowed us to actually validate what we had developed internally and to tell us what more we have left to do.
So this project has sparked some upcoming work for us that I wanted to touch on. First of all, the AARIP meeting is scheduled for tomorrow, and we're looking forward to getting going on that. Also, VDEM is about to release an EMAC reimbursement guidance document that is the direct result of participating in this project. We've been discussing incorporating an inject into our annual RAD exercises that are planned with both VDEM and VDH working together to incorporate mission-ready package requests. So that could be an exciting annual event. Also, we've been discussing incorporating behavioral health support into Virginia's EMAC briefings to make sure that deployed personnel have the behavioral health attention and support that they need both before and after their deployments. So this is a huge piece that I think will be really helpful for everybody in Virginia who gets deployed. And then finally, we're taking that Mission Ready Package workshop and putting it on the road to take to our special operations teams, our search and rescue, our incident management teams, and our hazmat teams to start developing Mission Ready packages. And with that, I will hand this back over to Angela.
All right, thank you, Kate. I think we heard a couple of really good best practices that I just want to call out. One is the Office of Financial Management, including them in the development of the Mission Ready packages. I noticed this firsthand in the workshop that I attended, where when you included the financial people in the development of the Mission Ready package, it really accelerated the development because you need personnel costs, you need equipment costs, and having those people as part of the development team was really beneficial. Another two were, updating your procedures and guidance from deployment all the way to the reimbursement phase. Again, a tremendous, lesson learned, I think, for all of us is we can do the exercises, we can develop the Mission Ready packages, but until we put all the pieces together, it's a lot harder to get these things on the ground. We have a number of questions. The first one is probably more directed to the state and to the public health personnel on the call. And we are joined for questions by Linwood and Karen from the Kentucky Division of Public Health. So welcome to both of you as well. Our first question is, what percentage of paid employees to volunteers are on the teams? So it's a pretty specific question. I'll open it up to Virginia and Kentucky and Arkansas if you guys have any responses to that.
This is Cindy Shelton with the Health Department in Virginia. I actually don't know what the percentage is. I know of all of our teams, behavioral health might be using some folks that they contract with locally through community services boards, and then the EMS personnel will not be VDH, but all the other Mission Ready packages we have will be health department state employees. That was a question I didn't anticipate, and I'm really not quite sure what the actual percentage is.
Yeah, I didn't expect it either, Cindy. Greg, Linwood, Karen, or Carol, do you guys have anything to add to that?
I think Arkansas is in pretty much the same situation here as Virginia. The only thing that I could potentially see having a volunteer is our behavioral health team as well.
Yeah, I would second that. This is Greg from Kentucky, just the behavioral health team. And also to remember, yes, we say that they're volunteers, but it's important to remember, too, that they do have to become agents of the state, so you have to do that. I would just go back and know your state's specific, if there's regulations or memorandums of agreement in place, because those folks do have to become agents of the state before they can be deployed under EMAC.
Great, thank you. Our next question, and I can answer this one, have any of the Mission Ready packages that have been developed been deployed in an actual mission? And the answer to that is not yet. These are actually fairly newly developed, and we've not had an event where they have been requested. So I'm actually looking forward to it. When we actually deploy the first one, will be a real a banner day for us, I think, actually. Our next question is the intent of the standardized packages to develop a national standard. And Cris, why don't you take this one for us?
Thank you, Angela. Yes, so what we attempted to do in the excitement that we're attempting to build and build upon here is to take those templates, taking a lot of the initial effort and a lot of the hard work, blending that with those that have been built under NIMS, as I said, and making them available on the EMAC website, on the MAS system, and then being able to have the lift by state to make them more personalized and customize an easier task, and therefore potentially and hopefully allowing for more build out into the system. So when the process of building the template is simply to customize certain pieces of it that we know are standard across the board, and then be able to alleviate some of the effort that will be absorbed by the state as they seek to customize them. And I would encourage everyone, if you haven't been on the EMAC website in a bit of time, I would encourage you to go onto the website and to look at all of the templates that have been built that are housed there, because you may find that the process of customizing it and building in some of your own resources, potentially without this support network that we've been discussing on this call, will be a task that you find beneficial and worthy of your time.
Thanks, Cris. Our next question, again, I think it's probably going to go back to the states. It's pretty specific. Out of the mission-ready packages developed in this project, how many, minus the ambulance strike teams, are NIMS resource typed? So we could maybe go state by state and say how many, of the 5 or 7 that you developed, how many of those were actually NIMS resource typed? And if you don't know, that's an okay answer as well, since you might not have it in front of you.
So this is Carol with Arkansas. I'll just start off. I'm going to have to say I honestly don't know. I was looking at the missionary packages this morning, but that was not one of the things I specifically looked at, and I don't have them in front of me, so I don't know for Arkansas.
So this is Kate from Virginia, and I have to say that I don't know offhand either. I could take a look. I know that most of the mission-ready packages that we have built in Virginia are not strictly NIMS types. Either the resource isn't something that is in the NIMS library, or the resource that we're describing is a little bit different from the NIMS type. So most of ours are not actually true NIMS types, but I can't tell you offhand whether or not any of our health ones are.
Yeah, and this is Greg in Kentucky. I'll echo what Virginia said. I don't believe ours are. We do make a good conscious effort if a resource can fit into the NIMS type, then we certainly want to be compliant with NIMS and type it appropriately.
And I'll just point out too that the NIMS resource type is the minimum capability for that resource. So it may not be an exact match for that resource. It's simply the minimum capability. So they meet that minimum capabilities, and they are NIMS typed to that minimum capability. Our next question is for Kate, and they actually said that in the question. In regards to Virginia's EMAC procedure update, how did you address backfill?
Backfill is a contentious issue. So in our EMAC reimbursement guidance, Virginia's stance is that backfill is not traditionally covered with EMAC, but if it is agreed upon between the requesting state and the assisting state ahead of time and included in the Rec A, then of course it would be reimbursable. So backfill, it really depends on whether or not the requesting state makes the exception to the rule and is willing to do that ahead of time.
Excellent. Thank you, Kate. And I will say that backfill in general for EMAC is not necessarily part of the Rec A process or part of that mission, but if the two states did agree upon backfill, then it is an eligible cost. Our next question is for Cris, and it's asking, what challenges did the pilot states face when developing the mission-ready packages?
Thank you so much, Angela. So I would say that the first challenge that faced the states was building consensus around which templates they were going to select to customize. And they approached that challenge in a variety of fashions. Some of them chose to survey the stakeholder groups that were going to be convening for the afternoon session, and prior to our arrival had already focused upon the ones that they wished to build. Others chose to use the opportunity to all be together for the full day session that I spoke of earlier, the half morning session dedicated to education and the afternoon dedicated to customization. Others chose to use the afternoon session to have an open dialogue with us present, helping to direct them to the ones that might make the most sense for them to select. And so they used a variety of approaches, all of which yielded successful results with respect to consensus and having the right people in the room that would be able to dedicate themselves to not only the afternoon session where we began the process of customization, but then linked us with the right stakeholder, individual stakeholder or groups of stakeholders to support the conference calls that continued after we departed the state for the purposes of continuing the building out some of the customization process that we were not successful in completing in the afternoon session. Angela, if I could take just a moment to go back to the question about the relationship between the resources that may have heretofore been NIMS typed, that the relationship between the templates and that.
Absolutely.
It's important, yeah, it's important to know that what we found interesting in the project, and I hope that it's inspiring for everyone, is we are seeing that while we looked to the NIMS resource library for inspiration for our project, we also are finding that the templates that have now been built, especially those that are in the EPI category, are providing inspiration, we're learning, for the NIMS team as well, and that they're looking at those to provide the footprint for their work. So I think one of the takeaways from this project is we're all in the same business, right? We're all trying to accomplish the same goals. So the fact that we're able to create these atmospheres where we're sharing information for the betterment of all, and this is cutting across, as we're seeing with the templates and the relationship back to NIMS resource typing, that's creating an atmosphere of collaboration that cuts across local, state, and federal lines, and I think that that's a really good byproduct of a very collaborative project.
Excellent, excellent points. Our next question asks, did you purchase new equipment for the mission-ready packages or use existing equipment? And I think for all the states, the answer is probably existing equipment. And if I'm wrong about that, please correct me.
That's correct, Angela. It was all existing resources.
Yeah, and that's one of the things that, EMAC really stands for, is the ability to leverage the federal dollars that are invested in these state and local resources, to leverage them through the EMAC process to go help other states and gain experience. And our next question is a follow-up on the volunteer question, and it asks, are MRCs used in the development of the mission-ready packages? And that's probably more for Cindy.
We are not including the MRCs at this time, basically because a majority of the packages that we've developed, we would not require their use. So at this time, we are not including MRCs in this.
Does that change in Kentucky or Arkansas, Greg and Carol?
Go ahead, Carol.
Go ahead, Greg.
Yeah, I was just going to refer, if my my public health counterparts, Linwood, is still on the line, they could probably address that from a public health standpoint. Linwood, are you there?
Yeah, we're not using MRC in MRPs.
And this is Carol. I don't have anyone from public health in the room with me today. We would have the capability of including them, but for the mission-ready packages they completed, they just identified the position, not the personnel. So without having them here, there's no way I can identify whether or not anyone would be MRC or not.
We had a comment come up that someone just said that the MRC program is working with NACHO and ASTHO in the development of MRC-specific mission-ready packages. So good to know. Thank you, Robert. And our next question, have you worked through the actual resource requesting process for your mission-ready package with any of the state offices of emergency management, or are you able to deploy directly without direction for your Office of Emergency Management? And I'll start this question. EMAC is implemented through the State Emergency Management Agency, so all requests and offers go through the state EMA. And Kate, I'll probably go over to you for kind of your exercise that you conducted to show how these work and how seamless the process can be.
So the second half of our exercise, we really walked through the process, and it starts with the deployed personnel coming back and creating their reimbursement documentation from their employer, which is typical, travel costs, things like that, per diem, and getting reimbursed. And then the resource provider, which in this case, is the Office of Radiological Health and the Virginia Department of Health, creating all the documentation for their expenses for the mission. So that would be the salary, the amount of money that they reimbursed the deployed personnel for travel, the equipment, all of their expenses, and then they submit documentation to the Virginia Department of Emergency Management, and then we would take a look at that packet, and at that point the packet would then go to the requesting state so that they can pay back Virginia.
Excellent, thank you.
And Angela, if I could just add, would you mind if I added a little bit to that? So it was it was really encouraging to see the incredible linkage between the emergency management agencies and the disciplines amongst their states, in this case the public health and medical resources, the recognition of that, the seamless integration that is necessary in order for EMAC to work. And so in the morning sessions, when we're kind of going through that EMAC 101, we are certainly taking the opportunity to amplify the points of confluence that they start with the emergency management agency, with the request arriving into their offices through their EMAC coordinators, and then the outreach that is happening from the EMAC coordinators that are housed in each of the state emergency management agencies out to the appropriate resource owners, if you will. So and we continue to amplify that both through the morning session of the education and in the afternoon section when we're talking about the building of the MRPs. And then to Kate's point, we actually exercised it, and we'll be exercising it next week in Wisconsin as well, the actual tabletop version of deployment, so that we're understanding again that points of confluence for the resource to move and be approved and be started, the packaging actually being deployed. So it was it's a very, very close partnership, one that was not created as part of this project. It is one that we celebrated and recognized as we looked to build out the EMAC system, but these are solid relationships that exist between the resource owners and the EMAC coordinators state to state, and it is a very well-oiled machine that we were able to watch in progress. The exercise that Virginia did, they even recognized an opportunity to continue to exercise their MRP capability through future exercises, and the exercise venue that they have already illuminated as an opportunity is the fact that they do radiological exercises, as do likely a number of the states that are on this call. They do radiological exercises throughout the year as preparation for their federally graded exercise for those states that house nuclear power plants. And there was a suggestion made during the hot wash of the exercise to say, hey, listen, this was a really good opportunity to move our resources and test our systems, to move our resources and commit to deployment in concert, in collaboration with the Emergency Management Agency. So let's take an opportunity the next time we're doing a radiological exercise to build in a component into that exercise that's already taking place and is already a number of the tasks are pre-scripted. Let's add this in as well so that we continue to stay fresh on the deployment of resources under EMAC. And so I would encourage folks, in the interest of best practice, to think about possibly incorporating that into your own exercises, be it radiological or the other genesis, to be able to continue to keep fresh the opportunity to move those resources under EMAC.
Excellent. Thank you, Chris. Chris, this question might be good for you. It is from our own Leon Schaefer. He's asking if it is possible that mission-ready packages may be typed according to size and capability.
I mean, I think the short answer is yes. Yeah, I mean, I think there's definitely an opportunity to do that. We're looking forward to both having inspired folks to continue to build out this process on their own, as well as I think Angela will be concluding with some opportunities that exist for some additional states to participate in this particular project and continue to build out the MRPs. But I think the simple answer to that is yes.
Our next question, which states are regularly using mission-ready packages, whether public health, medical, or other types? I understand the concept, but I'm not sure whether or not implementation has been successful. So I think I'll start that by saying we have a number of states that have been developing mission-ready packages. It really started as an effort in the QSEC region, so the 8 states who deal with all the earthquakes. Arkansas was a real leader in this, and really the Gulf states have picked that up and have been continuing the development, and it's kind of grown up kind of the East Coast and now spreading rather quickly across the nation. I will say from the operations side of it, since I do see the offers of assistance that are made when there are resource requests, we have a lot of the offers of assistance being uploaded through mission-ready packages, so that's becoming more and more frequent that anytime there's an offer of assistance, it's uploaded as a mission-ready package, which for us, is really great to see because it means kind of full circle, and we also see that those missions go from request to Rec A completed much more quickly. So a real success story for us, and I'll probably go back to Carol and Greg and Kate if you have anything to add on that.
This is Kate from Virginia. Yeah, I would just want to add that Virginia in the past several months has had several requests for assistance that never actually turned into missions, but the work that we did became the foundation of a mission-ready package so that we don't have to feel the pain again and scramble next time. And also everybody across the nation can be aware that Virginia has this capability because it's already uploaded into MASS.
Yeah, this is Greg, and I would again echo that. We had, it wasn't health related, but just to give you an example, we had some of our search and rescue folks wanted to assist during Hurricane Sandy, and they had no existing mission-ready package. So by the time it took those folks to go ahead and complete the offer, which was 18 plus hours, all those missions were already filled. So they kind of learned the hard way, and now, though, as a result of that, we have developed some additional mission-ready packages.
And this is Carol from Arkansas. I would like to say that, yes, we have, a lot of the states have worked very hard to start incorporating mission-ready packages into their efforts to move forward. One of the things that we have done is that every time we have filled out an offer that we did not have a mission-ready package for, we have added to our policy that is the next step, that we turn that into a mission-ready package or start with the creation of the mission-ready package and upload it, just to help us build that larger database.
Great, thank you. Our next question, have there been any coordination challenges with building mission-ready packages with teams staffed with local units? I'll probably go to Linwood if you have any input on that one.
Who did you toss that to, Angela?
I tossed it to Linwood in Kentucky. He might have been cut off. Greg, do you know if any of the Kentucky teams are more local responders?
I think what you'll find is with the ambulance units, the EMS strike teams, most of those are local responders. And I know every state's different, but our resource owner for those is the what we call K-BEAMS. It's the Kentucky Board of Emergency Services. So they also regulate the ambulance services as well. And that's been a real plus for us, is they're kind of the tip of the spear when it comes to EMS services. So they were able to organize, and they're able to also maintain that MRP for us. So anytime we get the call, they can choose from a variety of different local providers to be able to make up that strike team, and they do that work for us.
Excellent, thank you. Our next question is two parts. I'll answer one part, and then I'll ask kind of the states to chime in with their answers on whether or not their mission-ready packages are based upon a 72-hour deployment. The second part of that question is whether or not they are expected to be self-sufficient. So I'll answer the self-sufficient question first, which is if a mission is expected to be self-sufficient, that will be part of the request for assistance. So that will be very clear up front that the resource is to be self-sufficient for the duration of that deployment or for part of that deployment, and that's very clearly laid out in that request. And the next question is really what's the prep time for that resource to deploy? So is it 72 hours or something different? And I'll probably just ask all the states kind of, if they know offhand, what's the average number of hours for a resource to be able to prepare to deploy? And I'll start with Virginia.
So I think we've got a wide range from I think 4 to 72 hours is our range for the public health MRPs we just made.
Excellent, thank you. Greg?
Yeah, anywhere from, off the top of my head, anywhere from 6 hours. I think our ambulance teams, which are throughout the state, have to get organized, and I think they're upwards of around 36 hours.
And Carol?
For hours for the patient transport teams, they all have a 12-hour deployment time. For the EPI team and the foodborne disease EPI team and the behavioral health team, they both have a 24-hour deployment time frame.
Excellent, thank you. And our next question is for Cindy. What are the training requirements for the teams?
Sorry, I didn't catch all of that question.
What are the training requirements for the teams that are part of the mission-ready packages?
I'm really not sure where one's going with that question. If it's, they're basically performing a lot of duties that they would in their regular job, so I'm not sure.
Exactly. And I think that is kind of the point of it, is there's not a special training. They're really doing the same duties they do in their normal job with the same training that they get for their normal job.
The thing that's different, and this is why we put together those packets to be job aids, is what they need to be aware of in conduct of doing those duties. Like, you know, the timesheet that's different than what they would fill out if they were on a regular job assignment. So that's not really training.
Right, exactly. Our next question, and I'm not 100% sure what we're asking here, so Cris, you may have to help me out. Did you consider developing mission-ready packages that include federal assets which might be needed for a catastrophic disaster? The deployment process is obviously different for federal resources and EMAC. So typically they are not part of an EMAC mission-ready package, although federal resources can be deployed through EMAC. For instance, some of these search and rescue resources that are federal teams can be deployed through EMAC. Cris, did you read anything else into that I missed?
No, we did not. We focused purely on state resources that existed within the states. We did not have any discussion about resources that were outside of the, into the federal space.
Excellent, thank you. Our next kind of a statement is about the inclusion of local resources in mission-ready packages, and in North Carolina stated that the biggest issue they have in developing mission-ready packages for local resources in North Carolina is the calculation of the fringe benefit costs. So they usually put averages in the fringe benefit costs in the mission-ready packages to help expedite that process. Our next question, how do mission-ready packages differ from detailed emergency response plans? And Cris, you might be able to take that one. I think they're two completely different things.
Yeah, I don't actually, on its face of the question, I'm not sure I understand the linkage. In my head, they're completely different. So
that's what I think.
Apologize. Yeah, I apologize for not fully understanding where the question might be headed. But in the question's purest forms, I do not see any linkage. They're two completely distinct, both necessary to have as part of your preparedness process, both the packaging of any available resources as well as appropriate planning documents.
Right, and I think as far as developing the emergency response plan, the mission-ready package would be part of that plan. So you could work with another state, like a neighboring state, to identify mission-ready packages that you may need during a disaster based upon your list of shortfalls, or you might be able to offer mission-ready packages to another state and include that list of those mission-ready packages in your emergency response plan. So hopefully that is helpful. Let's see. I think probably our final question, since we're a bit over on time. What have you learned about making volunteers an agent of the state? What hurdles have you faced, and how have you overcome them? And I'll start that off by saying each state, there's really 4 mechanisms to do this, and each state usually picks one of those 4 mechanisms. So if Kate, if you want to talk about how Virginia makes locals agents of the agents of the state, we can start with that.
So the way that Virginia is doing it is that for the transport teams, the folks there are activated through the locality. So the locality is using them as their resource, even though they're not technically employed by the locality. And so we have the agreement with the locality to use that locality's resource. So we have an intergovernmental agreement that we use. I'm not sure if that answers the question.
I think it does. I mean, so I think what we'll see is one of these different ways to do it. So in Virginia, it's an intergovernmental agreement based upon the resource. It could be legislation in the states. So for example, Iowa uses legislation that brings local resources on as agents of the states. New Jersey, for example, would use a governor executive order. And again, I think it's different for every state. So the important part of that is when you're developing a mission-ready package, you need to work very closely with the State Emergency Management Agency to work those type of things out before you would develop that mission-ready package and make sure they have the enabling mechanism in place to deploy that resource in a timely fashion.
Right, and Angela, if I could just amplify that a little bit, we
Sure.
saw even amongst the 5 pilot states that there was a variation with respect to how they incorporated volunteers into their mission-ready packaging deployment strategy. So I would encourage folks that are on the phone that don't yet know the answer to how you incorporate volunteer resources into your mission-ready packaging, that you go back and ensure that you actually do have the enabling legislation or governor's executive order or whatever the enabling document is that will allow you to harness that incredible resource of that's available to all of the states, because we saw great variation in the ability to incorporate those resources. And there is, I think unilaterally we saw, at least in the 5 pilot states, that everybody wanted to find a way to get to yes. How do we use them, recognizing that they are such a force multiplier in the ability to enable more resources, more human infrastructure resources to bring to bear on a particular challenge that you have. So I would encourage everyone, if you don't know the answer to how you do that in your state, that you go back and make sure during time, quiet times, non-emergency times, that you have the right enabling infrastructure in place to move resources and roll them up as agents of the state. That's ultimately what you're looking to be sure is in place, that volunteers can roll up as agents of the state and have those same protections in place if you're mobilizing them under MRPs. But it brings an enormous force multiplier to your team, and one that reaps great benefits for your recovery.
Absolutely. Thank you, Cris. And I'm going to close this down. Thank you to Cris, Carol, Greg, Linwood, Kate, and Cindy for presenting today. We really appreciate your expertise and lending your experience. Thank you again to everyone for joining us today, and we'll sign off.